my experience is everybody loves coordination. Nobody likes being coordinated. So, we talk about integration at the program level. It must be a nightmare sometimes. Do you want to give us a little bit of your insight, how you manage that and what we as a community with malaria can do things better to make your life easier?
Okay.
Yes, sometimes it can be a nightmare. Is it working?
I think so.
Okay, it can be a nightmare, but one of the things that is helpful as a program is first have a very good strategic plan which is done with all partners involved so that your nightmare is reduced. And once partners are involved, we don't get partners trying to do things differently. And that is the beginning of the planning phase. So the planning has to start early for us to all understand that we are doing this way and doing that together. And involvement of stakeholders, not just at the national level or at the regional level, but at the community level in terms of people who would use the tools is also very important. Identifying the resources that are needed to make integration possible is key. And resources, I'm not just thinking about money, but resources include really, really human beings. And sometimes in most of the interventions that we do, we are looking at the tools, but we sort of put the human resources at the backbench. But they are I keep saying in our country that the human resource is the number one tool. So having that thought through the integration process and making sure that you are putting that on top. Which human resources are going to do it? How are they going to do it? What capacity is key to making sure that integration is very important. And we should never, ever forget why we are integrating. Because sometimes when we miss that, we miss it along the whole process to make sure that as much as we integrate, the final goal of the integration is not missed. Thank you.
Great, thanks, Kitty. A really important reality check for all of us who are looking at pieces of the puzzle, and you've got to really be looking at the whole game here. Please, don't be shy. I restricted everybody to 5 minutes, and they could have spoken for an hour, so try and find out what would have been in the other 55 minutes for any of these talks. David?
I'll try not to be shy. So I think this is really wonderful, and I think we're seeing the convergence of all these tools that can really change the landscape over the coming years. So I really share and I'm encouraged by your enthusiasm and optimism for the future. So we have seen in recent years, obviously, since 2015, that despite the tools we have, like Coartem being effective and good insecticide-treated bed nets and vector control measures, that, as we know, the burden has gotten worse in sub-Saharan Africa. And so I think this is a great panel to ask the questions. What do you see as the major drivers for why it has been hard in the past decade to continue the downward trend, and on the flip side of that question, what tools do you think would be the most effective in your local regions that could really sort of reinitiate the drive towards malaria elimination? Thank you.
Great question, David. We have to be nice and let him have a question. He's the next president, so if you want to get invited back to Toronto, he's the man to suck up to at the moment. I think that would be a great question to take on a couple of different levels. I think maybe let's start with SEDU and the angle of implementing within countries. Then maybe we can move into anybody else who wants to take this about the development of tools. But SEDU, please.
Okay, well, I see several factors. One of the easiest one is an example of sustainability. When IRS was implemented in some district in Mali, so we saw a very nice decrease of malaria incidence. And then same thing with Jeff Sachs' Millennium Village in Joro. So every health indicator were very improved. And when it was stopped, then we see an upsurge. So you see how sustainability in these intervention tools make the difference. Another way that's also why I emphasize on the implementation part. We think everything is good, but how do we deliver this intervention also still make difference? We make one investigation on IPTP, asking women what they think about the drug we give to them during antenatal care. So they said, oh, they merely give us, we merely swallow, meaning that they receive anti-malaria drug, nutritional supplement, and they don't know how to do it. And so it doesn't make any sense to them. And the other issues also I've been talking about is the health workers or even the program, how we combine all this. SMC, you give SMC for 5 months, and we realize that at the end of SMC, you have at least 20% of people who carry the parasite during the long dry season, and then when the rainy season starts, so we have not only problem of delivery, combination, sustainability. So those are just some elements for me which are barrier to elimination. Thank you.
Thanks, Seydou. A really important perspective from that. Maybe we just counter that a little bit with one of the speakers who spoke about some of the interventions coming in. Actually, is that an accident that you've got that in your hand, or were you going to answer
It is
this?
a complete accident. It's like a
Everybody
hot
else-
potato.
Everybody else took a step backwards, and
Yeah,
you're
but I'm happy to say.
But we'd be delighted to
few
hear from
things.
you.
Yeah, well, I think just coming back to the point on delivery and the importance of delivery. I mean, we can have the best tools in the world with the highest efficacy in clinical trials, but if we can't deliver them, they're not going to have the impact. They need to be deliverable. They need to be affordable. And I think just again, to come back to the point of the power of the EPI platform. You know, even in in very poor countries where resources are very limited, it's not unusual to see 85% of children getting their vaccinations through the first year of life. And so we know vaccines are a great tool for combating infectious diseases, but I think we need to think about that platform and the value that that platform brings, that we can relatively quickly slot new tools into the platform. And if we're smart about how we develop the tools and the schedules that we use, they can quite quickly drop into that platform, and we can get to 50, 60, 70% coverage quite quickly because we have the platform in place. So I think, yes, vaccines are fantastic, but we have this platform. And then how can we leverage that platform to then co-deliver other tools? Why not deliver a bed net when the children are getting vaccinated? Why not give perennial malaria chemoprevention when the children are getting their first and second dose and the vaccines are not yet providing full protection? What we have to strive for is vaccines that can give us solid protection based on contact in the first year of life, right? So right now, we know if we continue to boost the children the second year of life, the third year of life, and the fourth year of life, we can extend the benefit of the vaccines out further. But to Adrian's point, what we want are vaccines that we can give maybe 2 or 3 contacts in the first year of life, and then we're going to have durable immunity that can potentially last through the first 5 years of life, and then that access and contact challenge that we're faced with many of the current tools could be mitigated. So that's really one of the goals of future vaccine programs.
Thanks.
I would say that from a drug perspective, I think simplifying regimen is very important. If you simplify the regimen, you will increase that adherence. And of course, from a resistance perspective, I think that we understand a little bit better maybe what we need to do and which kind of drugs we need to combine in order to tackle that resistance. And I don't want to talk about the irresistible. We don't talk about irresistible anymore. We call it refractory to resistance or high barrier to resistance. But, it's a very high bar. But I think that, combining drugs that maybe have medium or risk of resistance, propensity to resistance, maybe that is the way to go. But to me, simplifying the regimen, this is why we're very excited about this long-acting injectable. It's one shot with 2 drugs in it that can give you a duration of 6 months, and and it clears the parasites. So you start targeting that parasite reservoir that we are now looking at. Pregnant women, they've been neglected, particularly first trimester. So there are still a lot of gaps that doesn't let us bend that curve.
Might comment on something a little bit more basic, which is ultimately, is the demand outstripping the resources which was available to keep up? I mean, that's got to be a significant contributing factor to that gap. And when we look at, looking at the example of nets, the introduction of the dual AI nets, clearly a significant improvement in efficacy, but there's also an increase in cost, and something has had to give, and we've heard from Seydou, there's Mali's one country where IRS programs has basically, there's been decisions made around prioritizing dual AI nets versus IRS. So there are trade-offs, and I think, do we have a clear understanding about that kind of pace and increase in demand, and whether or not we actually really got the resources to keep up, and that's got to be a contributing factor.
The way I see this is slightly different. I think you've got two options. You carry on doing what we're doing at the moment with incrementally better tools and better control and hopefully impact in every country that has the resources to do that. And you carry on spending around about $5 billion, not million, dollars a year doing that. By the way, just on the vaccines bit, a tiny fraction of that is buying vaccines. The other way of doing it is to decide you're going to do a pilot program somewhere and find out what it actually takes from all these interventions we've heard about